program today. Perfect. Ruth, I have 1 o'clock. So I know that you and Andrew are excited to get this program kicked off. So I'll turn it over to the both of you. And Andrew, we're so glad to have you.
Thank you, Hudson. I appreciate that. Good afternoon, everybody. My name is Andrea Flincham, and I am the manager of the Healthcare Associated Infection Prevention Program at the Department for Public Health. And I want to welcome you to Making Sense of the New OSHA ETA, A Journey to Compliance. I'd like to say a special thanks to the Center for Education and Training in Infection Prevention. They are part of the Division of Infectious Diseases at the University of Louisville, and I am eternally grateful for their partnership. And I know that this is going to be a great session. So without further ado, I will turn it over to Dr. Ruth Carrico.
Thank you, Andrea. And it is a delight to have everyone today. You know, I think all of us right now are struggling with how do we make sense of the information that we get every day, sometimes multiple times a day, and then how do we translate that into ensuring that we have a safe environment of care, not only for the patients that we are caring for, but equally as important, and sometimes even more important, how do we make sure that healthcare workers are safe so that we can return to work, do what we do best, which is provide care for our communities. So it becomes critical that we have a good understanding about what we are getting from OSHA, how we can take this emergency temporary standard, implement the components, how do we deal with components of any guideline or standard, which we're all aware of. We know that in this very fluid time where we learn about COVID-19, the coronavirus, SARS-CoV-2 every day, we expect that our guiding documents will also change. So it's going to be up to us to understand the baseline information, the background, and then be able to stay abreast of these changes. So I'm very grateful to Dr. Hudson Garrett for helping to put this together, bringing the information together for us. Working with Sarah Bishop, one of our nurse practitioners extraordinaire in the center with a tremendous amount of expertise in infection prevention and control, Hudson's background in infection prevention and control, the regulatory aspects, and a broad area of expertise in a variety of healthcare settings, and leadership and improvement. So between these two people, we bring together a tremendous amount of expertise. I'm grateful to both of them for putting this together, and I look forward to hearing their presentation. And I appreciate the ebook that I think Kim added that ebook in the chat. So please, everyone, be sure and grab that so that you have access to the information that's put together that will help you then figure out this process as we go along, and know that we will certainly be coming back together to provide follow-up information as together we learn how to deal with this. So without any further ado, let me turn it over to Hudson. Thank you for putting the information on CE, and I don't want to take any more time away from your presentation. So let's get started.
Awesome. Thanks very much, Dr. Carrico. And Andrea, thanks so much for joining us today. We're excited to have you here. This is really a hodgepodge of so many different factors that have taken place over the last year and a half. So Sarah and I are so excited to be here with you today. Before we get started, since we're offering continuing education for our nursing colleagues, Terry Goodman and Associates is an approved provider through the California Board of Nursing. You will receive 1.5 hours of credit for today, including the question and answer. In order to receive credit, you'll need to attend at least 90% of the total activity, which is 1.5 hours. If our Q&A goes a little bit short, no issues there at all. And then upon completion of the activity, we'll be sending you an email link which will allow you to do your online course evaluation. That will take about 72 business hours in order for you to receive that. If you do have any questions whatsoever, or you don't receive it after that 72 hours, so think about that as sort of Thursday morning, you're welcome to email my group at continuingeducation@chaassociates.com, and we'll be happy to help you. So we'll go ahead and jump right in. Again, if you've not scanned that barcode, I'll give you one more opportunity to do that. Not an issue. If for whatever reason you miss it, we'll pull it off the registration report as well. Once you do get your certificate completed, your online evaluation, you'll be able to download that CE certificate in a PDF file at the end of that evaluation instantaneously. Since we're offering continuing education credits, here are my financial disclosures, and Sarah has none, so that you've got access to those. So, when we think about this whole topic, Sarah and I were sort of joking about, this is almost a little bit too late, right, with this whole topic. We've been dealing with this for the last year and a half, and it's been a challenging situation, whether in long-term care, primary care, a hospital. Certainly all of our colleagues at public health have had a big challenge as well. And Andrew, I really want to shout out to your whole team for the great work that they're doing in supporting our healthcare colleagues across the state of Kentucky. But I think we can all agree that there's been a lot of confusion, right, from many different angles. This pandemic has caused people to question things that they have not questioned before. They've caused us, hopefully, to have great conversations that were productive about what we can do to protect the workforce. And that really leads us into today's topic, right? This emergency temporary standard that has been put out by OSHA. Sarah and I were sort of talking a few minutes ago, and we both were thinking, well, this is actually probably one of the best resource things that OSHA's put out in terms of providing supporting documentation, some tools and resources. But yet it also came at sort of a time that many of us were doing a lot of these aspects before. This is going to be part of at least a two-part series, which we'll talk about at the end of today's program. And we've also included a whole host of information in your ebook. As Dr. Carrico mentioned, I'd invite you to download that. You'll find that the slides are available in two different formats in case you have eyes like many of us that are starting to be a little bit challenged. You'll see that the slides are in 1 per page as well as 2 per page. And then right behind that are all of the different OSHA resources that Sarah and I will be talking about today. So the first thing that I'd like to dive into is sort of this directive from OSHA, right? And OSHA is really taking a lot of time and emphasis around really pulling together both resources, but also looking at enforcement action regarding this particular topic. This is a big area of focus for them, right? And rightfully so. As we've sort of mentioned a few times now, I wish that this same emphasis had been present many months ago, right? Where we had employees that were put in harm's way in some circumstances, whether it was due to inadequate or unavailable personal protective equipment. Maybe they didn't simply have the training or the access, and certainly the staffing and overwhelming aspects of a continued pandemic are out there. And so this is one of the resources we've included in your ebook, and I would encourage you to look at this, particularly the inspection procedures, right? It's almost a behind the scenes look at what are those OSHA inspectors going to be following as their template for a complaint or for an inspection. Very similar to what we go through with CMS. We want to have an idea of sort of how are we going to be scored and measured, and what does success really look like? And keep in mind that OSHA has one singular focus, right? They're focused on the employee, not the employer. So they're going to be completely interested in what steps can be taken by the employer to protect the workforce. And there's obviously a huge attention around the healthcare workforce with the number of individuals that unfortunately in the healthcare team that have gotten COVID. So this is not just sort of a standalone siloed approach, right? We know that our colleagues at CDC and CMS have put out a lot of focus on what we can do to improve healthcare practices related to infection control. But we also recognize that OSHA is sort of that unique regulatory body that is designed to protect the workforce, right? Whether that's if you fall into a hole on the side of the road where they've dug a ditch, whether it's falling off of a light pole, for example, or it's something like COVID in the workforce and we're required to provide adequate PPE. OSHA has a lot of broad authority associated with workplace protections. And so they recognized back in June, right, that the SARS-CoV-2 virus was posing this grave danger, particularly with our healthcare providers. And supported by CDC data, we've seen that so many healthcare professionals have really, been a victim of some of this issue. Cedric, I saw that you raised your hand. Did you have a question? Okay, guess not. So again, thinking back to sort of the CDC data point, remember that they've changed a lot of different things. For example, the way that breakthrough infections are reported. And so we do, however, know, especially in healthcare settings, a fairly good idea of how many healthcare workers have contracted COVID-19. And unfortunately, many of those workers, as you can see here, did not survive. And anything above 0 in that category, I think we can all agree is not good. We want to do everything in our absolute power to protect our colleagues and our teams. So OSHA really stepped in and said, what can we do to sort of treat this like an imminent threat? Think of this as almost like an ongoing sentinel event in Joint Commission world and sort of put out this guidance to address this. So what does this really all mean to us? Well, in some cases, you may be doing a lot of this information. And so that's good. If you're not, really the purpose of today is to give you some ideas to think about, ways to implement this. And then sort of our second webinar program that we're going to come behind this with in 2 weeks is going to talk about physically implementing some of the aspects of this within your individual care setting, right? And so some of these provisions then went in place back in July. And you'll notice that OSHA is very, very closely aligned with what both CMS and CDC guidelines are. However, we know that OSHA traditionally is not going to rush things out. And so unlike CDC, which may be publishing updates every single day, OSHA is going to take a little bit more of a slow approach as it relates to some of these documents that will be coming out. So what are the requirements? And I'd like you to sort of think about this in the context of your individual practice setting, right? Some of these are no-brainer and don't require a ton of customization, but others very well may. Things like developing a COVID plan. Well, there's a great template that is available on the OSHA website, which again, we'll be focusing on for the second program. But how do I sort of make this my own? It's almost like if somebody were to give you a script and say, this is what you're going to read. But if it's not your natural vocabulary and sort of how it looks and feels within your facility, it's really difficult to take someone else's approach and then easily implement that within your own practice setting. And so hopefully today you'll think about some tools and resources to do that. What are best practices for screening, right? And sort of management of visitor flow. You know, for those of you in long-term care, especially, you know, the lack of visitation over the last year for your family members of your residents was particularly difficult. We went through that same exercise in acute care as well. But we've got to find out what's that right balance of safety and protection for the workforce, but also still managing sort of the humanistic aspects of clinical care delivery. We know especially that good clinical data shows us that if families are present, people heal more effectively. Sarah's going to give us a great overview of sort of this mini respiratory protection. And I'll tell you, every single time I ask somebody, what's your most sort of top of mind concern about pandemics? They always come back to respiratory protection. They're so worried about that, right? If this is a droplet, or even in some cases, we deal with airborne transmission with respiratory things, how do we take the necessary steps to protect the workforce so that regardless of when I come to work, that I have some type of good, solid respiratory protection? You'll see that there's a renewed emphasis for some of those CDC core practices for infection control. Things like standard and transmission-based precautions. Knowing how a pathogen is transmitted is so helpful in identifying the risk of transmission, but also thinking about risk mitigation. If I know a pathogen is transmitted via aerosol, then I know how to stop that. If I know it's an airborne transmission, then I know how to stop that. If it's contact, then I know how to stop that. I don't have to know every single thing about the pathogenesis of the pathogen, but I at least need to know how it's going to be transmitted from person to person, or even from the environment to a person to another person. What about cleaning and disinfection? Right? You know, when I look at especially hospitals here lately, we've gone back to sort of that sense of normal. We're not doing that enhanced cleaning and disinfection in many cases. Ventilation is another huge area of concern. We want to make sure that we minimize the amount of infectious aerosols that might be circulating within that environment. One of the big ones that I've highlighted here is sort of the importance of health and occupational screening. You know, I've got a colleague actually that was exposed to tuberculosis. Nobody contacted her and told her until several days later. And now they're just now going through the process 3 weeks after the exposure. And so that's an example of where the system broke down. And with COVID, we've learned that we have had lots of exposures that we need to take the necessary steps for to protect that workforce. The importance of vaccination. You know, we are all working healthcare, and so we've seen the benefits of vaccines, whether that's in your child with vaccine immunizations, the elderly with things like shingles and pneumonia, and now, of course, with our COVID EUA vaccines that we have available. Lots and lots of circulating topics around that we could have a whole probably 2-hour webinar on. I think Sarah would agree just with that alone, but we do want to promote that, make the information available, and certainly be a conduit to answer questions. I have talked to so many people, and I can't think of a better vaccine expert than Ruth Carrico, and I really lean on her strongly when there's certain sort of nuances. But I find that most people that have questions, they simply want someone to hear their answers. And sort of hear those questions out and provide them some evidence-based context that makes sense. And lastly, you'll see sort of training and sort of this what I call workplace sort of culture, right? Good leadership, making sure there's anti-retaliation standards in place, that we're maintaining adequate records to fully understand the risk of transmission and also the true impact of our data. So, what about sort of approaches to this? I tend to go back to the personnel first, right? I want to look at people, process, and product in that order. Do I have the right personnel at the front lines that are able to care for the patients, the residents, the staff members, whoever it may be? I'm going to focus myself on a process like transmission-based precautions and cleaning and disinfection, appropriate use of PPE, hand hygiene. And then I'm really going to look also at product management, and not physical products necessarily, but how do I use technologies that might exist?
Tilford has not gotten here yet.
Okay, Tilford's not.
I'm sorry, if you could just make sure you mute your lines, we would greatly appreciate it. Thanks so much. So what about developing a COVID-specific plan? One of the things that is interesting is we want to have that sort of workplace safety coordinator. Now, that may or may not be the infection preventionist. In long-term care, it could be a variety of different people. But we want to have someone that's got both knowledge and also empowerment to take action. Someone who has really been, supported by senior leadership. And you want to have that senior leadership team be engaged in this process so that as we identify obstacles, we can remove them. If there's resource needed, we can bring them to bear. And if there's discipline, unfortunately, that's required, that we have the process in place to be able to take that into account. But we also have to measure the effectiveness. It's all about that ongoing quality improvement. What can we do to impact change, measure that change, and then tweak it as we go? Every single day, my sort of personal philosophy is to learn something new, whatever that is. It may be something new professionally or personally, but that makes me 1% better than the day before. Think about that and sort of the impression that you want to sort of consider about how do I really document this, report this back to leadership, and probably equally as important is share this with my ongoing frontline teams, right? You want to have somebody that's got that knowledge base. Now, that in sort of combination with your workforce hazard assessment is where you really get down into the nitty-gritty. If you don't have the fundamental building blocks, I think about this in terms of Legos, right? If I don't sort of put the foundation of that house down, I can't have my kid build the Lego house. And it's the same way here. So that person, again, needs to have empowerment, leadership support, but they've got to have some level of foundational knowledge to understand this information. So I wouldn't necessarily go pick someone, for example, in human resources, or even someone in administration. They can be part of my team, but my workforce or workplace safety coordinator needs to be somebody with basic knowledge of those core areas that we're going to talk about. And then lastly is to implement those policy and procedures, right? Who can I get on my team to help me do this? How can I measure that success unit by unit? What does success even look like? And how can I make sure that honestly, the staff at the front lines feel the impact of the plan, right? If you walk around and they can't even describe the plan or what the plan is, then Houston, we know we have a problem associated with that. So what about personal protective equipment? This is one of the areas that you've got to really focus on clearly, but also think about this from a supply standpoint. We've all been through the sort of phase where we couldn't get what we wanted, right? Those face masks that we've always used for years, they were on back order. The ones that were substitutes, those were on back order. And then the ones that we got were imported from another country, and maybe they even came in as damaged. Sarah's got a great slide looking at counterfeit information. And, never did I think that we would ever have that conversation in the US, but here we are. I also thought we would never run out of toilet paper, but here we are as well, right? So we've got to think about this in the context of the greater good. PPE is that last line of defense that we can use to protect the workforce. How can we make sure that people are appropriately using it? Things like fit testing, ensuring that if they have a different type of mask or a different type of gown, that it properly fits. We want to look back to the FDA's clearance process in order to vet these products. And it's not a foolproof solution, right? But they do have lots of great resources on FDA.gov. You can click on that coronavirus tab, and it will show you from a COVID standpoint, all of the FDA cleared devices that exist out there. There may be some circumstances where we reuse things, whether they be respirator protection or even gowns, and we want to make sure we're following the manufacturer's instructions. As it relates to aerosol generating procedures, of course, we want to use that highest level of respiratory protection with an N95 or higher. And again, Sarah will talk a little bit more about that mini respiratory protection program, especially for facilities that may not be their normal activity. Right, so what about sort of face mask in general? You'll notice that the ETS does provide that exemption for fully vaccinated workers for masking, distancing, and barrier requirements in well-defined areas where there's no reasonable expectation that any person with suspected or confirmed COVID will be present. Right. And so this is confusing and almost contradictory in some aspects, because if you read further, it says unless all are vaccinated in every area of a healthcare facility, there's no reasonable expectation that an unvaccinated or infected person is going to enter that space, and therefore is not likely to be the case. So this can provide a little bit of contradiction. That combined with the most recent CDC guidance that's come out regarding the Delta spread. So we want to follow CDC guidance, but we also need to make sure that we're appropriately implementing this within the context of our particular institutions. So what about social distancing and barriers, and really how effective are those? Well, keep in mind, there's not a ton of evidence-based data around some of these things, but it certainly makes sense in some aspects. If I have a physical barrier between person A and person B that is high enough, right, to sort of prevent that respiratory droplet spread, then there could be some value there. Certainly if you've got areas where you've got folks that are extremely fully vaccinated, and maybe they've got great air circulation, then those areas can be exempt. They're not required in actual patient care rooms as well, but you'll see them a lot of times at places like registration desk and check-in and triage, some of the areas where it may not be possible. We've even seen this in nursing station where you've got multiple different personnel that are sort of crowded in there, a variety of both vaccinated and unvaccinated persons. But you also don't want to go hog wild with this, right? So we want to make sure we're being pragmatic in our approach. We know that plexiglass and sort of these barriers cannot be the end all be all. They're just another tool in our arsenal that help us do that. So what about good practices as they relate to cleaning and disinfection? We've talked about some of these core things like appropriately wearing your mask, using PPE, understanding modes of transmission, but cleaning and disinfection of that inanimate environment can be so helpful. But there's a couple of sort of tricks that I always like to follow when you think about this term. Cleaning, of course, is going to be the physical removal of bioburden or soil, whereas disinfection is going to be that actual inactivation of those microorganisms. So think about that disinfection process as the sort of killing process itself of those bad things on the surface. We always want to use something that's EPA registered. The EPA is sort of the fundamental regulatory body that approves these types of disinfectant products. A broad spectrum is always helpful, right? Effective against bacteria and viruses, pathogenic fungal organisms, the bloodborne pathogen standard, which is also regulated under OSHA. And one of the big areas for opportunity, I think we can all agree, is sometimes we don't read the directions, right? Whether this be in hospitals or healthcare facilities, or certainly even in our own personal lives, we sort of fail to sort of do that. And I know myself, I'm guilty of that quite frequently, where I'll just throw those directions out and then I wish I had them later. And so following those manufacturers' instructions for use. The EPA has provided a new list that is specific for products that are deemed effective against the SARS-CoV-2 virus that's available on their website. You can search by EPA registration number, product name, or company name. But we also want to consider sort of the actual application of these types of products. Is this something I'm doing daily between cases in the OR? Is this something that we want to think about in terms of terminal cleaning? Or what about large scale applications like a school cafeteria or a college dorm, or maybe some of these larger scale applications? And the way that I've thought about this, for right or wrong, is to sort of take this in the same approach that CDC's done with PPE, conventional, contingency, and crisis, right? Keep in mind that that conventional sort of apparatus is everything's fine. We're not seeing back orders. We've got good product selection. All of the things that are sort of our traffic light are all in the green, right? And then we move into sort of that yellow light of contingency where we're starting to see back orders. We're making sure that we've got some of the challenges associated with getting the product that we want addressed. We may be getting backup or alternate products. And unfortunately, in the crisis mode where we existed for some period of time, that's where we simply can't get many of the things that we're trying to get in the first place. And luckily, unfortunately, that is not where we are here in the United States. So what about sort of this concept of this screening process, right? We want to make sure that employees are properly screened for sure, right? but we also want to make sure that it's done in a way that's going to be meaningful, impactful. This is one of the areas where I think that there's certainly going to be a lot of generalized confusion. We also have an emphasis, right, on the employee to tell the employer when they are either having symptoms or diagnosed with COVID-19. This should be part of sort of that employee handbook. We have to put some level of accountability back on the employee just as much. What about workers that don't follow our policy and procedures? That is a big area. And then we're going to provide that medical work protection for individuals that are going to have that exposure. So we want to be transparent. We want to be communicative. We want to make sure that we provide good resources to our employees, but we also have an obligation to make sure that we hold them accountable just as much as the resources that we're providing as well. So what about some of these sort of record keeping aspects? Well, we want to certainly keep good documentation to understand our true data impact. We want to understand how many of our associates are vaccinated. If they're not vaccinated, what are the reasons that they're not? That's always helpful data to understand. Where are they coming from? And are there things that we can do to bring them over to the other side? To give them that information that they're so starving for? Or is it just a reason that they won't disclose, whatever that may be? We also have an obligation as employers to provide training that is specific to that job role. And if someone brings up a concern, we want to, really think specifically about how can we make sure that we address that in a way that's non-punitive? Are there ways that we can do that without, affecting the individual's ability? So we do have some tools and resources here that we'll cover as well. And I'm going to transition in just a second over to Sarah, but you'll also notice that there's some of the appendix that OSHA has referenced that are available for you. We've included the hyperlinks at the bottom so that if you're looking for specific information, you're able to do that by clicking those links off the PDF file that Kim posted for us. So we're going to now transition away from what we call sort of that normal operation. And Sarah's going to talk about sort of that mini respiratory protection program. So Sarah, I'll turn it over to you.
All right. Thank you so much, Hudson. I really appreciate it. So I'm going to review the Mini Respiratory Protection Program, which is one part of OSHA's COVID-19 Healthcare Emergency Temporary. Let's see. It applies to specific circumstances specified under the ETS. So generally when workers are not exposed to suspected or confirmed sources of COVID-19 or situations where respirators would be used for other types of things. So it is not a substitution or intended to replace the normal respiratory protection standard. It's just something extra to help provide some guidance in these unique situations. So this just kind of overviews that. So if somebody is caring for a patient that's suspected or confirmed COVID-19 or doing aerosol generating procedures, or any of those other typical situations where we might be caring for an airborne patient, or maybe there's another workplace hazard. So maybe you have a decon area in your facility, then that's just going to fall under the normal respiratory protection plan that OSHA's had, and you're going to follow those guidance going forward. But this is intended for situations where a worker might normally use a face mask, but want that added level of protection of the respirator. Yeah. So why is this necessary? Well, it's all about taking care of our frontline staff and support staff. We need them healthy and safe so that they can do the important work that they do. So that's at the core of all of this. It's about protecting that workforce. So, there are many folks that, because we're in the middle of a pandemic, definitely want to utilize that higher level of protection, which is the respirator. But there can be hazards to doing that if you don't utilize it appropriately. So this is where this guidance comes into place, and employers have a responsibility, as OSHA is clearly stating here, to make sure that healthcare workers are utilizing these devices safely. So the mini plan is a way to do that, give some bare minimum expectations, and it's just easier and faster to implement than having to do that full, more robust plan. So for these situations. Okay. And this is just another nice little resource that outlines kind of what's involved with the mini respiratory protection plan. So for this, unlike the normal full respiratory protection program, you don't have to utilize the medical evaluation, fit testing, or even have a written program. But aspects of the mini plan do include making sure that your staff are able to do a user seal check and that they do get some basic training when utilizing these devices. Thank you. And I think it's important to kind of just clarify when we say a respirator, what are we talking about? So what's most commonly used in healthcare setting are N95s. And this just describes what those letters and numbers mean. So N, not oil resistant, 95% refers to the filtration rate, but there's a variety of different filtering face piece respirators out there. So those are included within this plan. And in addition to that, it also includes elastomeric respirators. So those come in half mask or full mask, as well as PAPRs or powered air purifying respirators. So if you have staff utilizing any of these devices where normally they would only use a face mask, then it is these expectations are going to fall underneath that. So a situation might be Mary Jane works in registration and she interacts a whole lot with the public, but normally she's not going to need to wear that N95 or higher level protection. But Mary Jane has asthma and we're in the middle of a pandemic and she wants to make sure she's safe. So she really wants to utilize one of these devices. So we want to make sure that she's able to have that extra level of protection. Now, if we say Mary Jane is going to be expected to go into a COVID-19 patient room and register patients inside of that setting, then that's where we're going to shift back to that normal full respiratory protection plan because we know she's going to be in that direct hazard. And so then we would utilize the guidance from that full plan in that situation. So, okay. All right, and then I included this because I think this is very important information for folks to use, whether you have staff that are bringing in their own devices to use, or if you are helping select N95s or filtering face piece respirators for your organization, just because we have all had challenges in getting the regular products that we use, and there are a lot of counterfeits out there. There's a lot of information on this slide, so you'll get all of this, and there's a link at the bottom that takes you directly to the CDC site where they give all of this information. But I do think it's really important to know how to tell if what you're using is legitimate, and if you are going to be allowing staff to bring in their own devices, which we'll talk about in just a second, that it's helpful for them to know if what they're using is potentially counterfeit or not and how to tell. So just wanted to share that. So within the mini respiratory protection plan, there's kind of these two tiers. So one is if the respirator is being provided by the employee. So they're going to bring in their own and they want to use this. So under this ETS, as the employer can allow the employee to do so. However, they need to provide this notice to the staff. And it basically just goes over a respirator can provide additional protection, and that's great. However, if you do not utilize it appropriately or store it and clean it appropriately, then there are hazards that could exist. So it gives that user recommendations on what to do. So read and follow all instructions provided by the manufacturer. Keep track of your respirators so that somebody else doesn't mistakenly use it. Maybe they brought in their own elastomeric half face piece that they want to use, it's theirs. So making sure that they know that it's how to use it appropriately and no one else is. And then also that they should not utilize that if they encounter other workplace hazards. So if someone is going to be caring for a patient with COVID or suspected COVID, then the employer must provide that respirator in accordance with OSHA's full respiratory protection standard. So you just got to give them this little notice, and that's what's covered for that one.
Hey, Sarah, there were a couple of questions that came in just since we're on this topic about sort of the requirement of the employer to allow outside of the building respirators to be used. So can you just clarify that? Because I think there's probably 5 or 6 questions, and they're saying that right now their policy doesn't actually allow that. So I just want to make sure everybody heard what Sarah said, that there is that accommodation. So I just want her to reemphasize that for just a second, because there's a couple of you that asked the same comment or question.
Yes, so that's a great question, because I know early on in the pandemic that came up a whole lot, and I imagine it's still in place. So this emergency temporary standard does say that you have to allow the employee to bring in theirs. And again, this is if it's a situation where they would normally only be required to wear a face mask. If they are taking care of COVID or suspected COVID patients, or there's another workplace hazard, airborne isolation, or any other kind of thing, then as the employer, you need to provide that face mask. So that is something that might be a little different from the other plan that's specified. Ruth, I see you just popped on. Do you have any?
Yeah, so I think one big point, and one of the questions that I've gotten a lot of is people have said, well, it seems like that since we have a mini respiratory protection program, then that tells me that really I don't have to worry. I've never done fit testing. I don't have to do fit testing. I just need to make sure everybody knows how to put their respirator on and do a user seal check. And this is, as you said, this is not what that means. That this is not taking away any responsibility that in your setting, if you are providing respirators, and if respirators are needed in order to provide that level of respiratory protection for your healthcare personnel, then you've got to do the whole shebang. You need to have your written plan. You need to have done your assessment. You need to determine who needs a respirator and who does not, and go through fit testing and meet then all of the other portions of that standard. This is for those employees who say, I want to bring my own, I feel more comfortable wearing a respirator. And what you're saying is, if you're going to wear a respirator, then you need to make sure that we need to have a process in place that helps us make sure you understand how to put it on and how to use it correctly. This is, I think, almost a give area on the part of OSHA, but I think they're recognizing that people are wanting to bring in, or they may have KN95s that are not truly, do not meet the respirator definition. But a lot of people are using them at work. And so if they are, you need to know how to use whatever piece of PPE you are bringing into the building or have available in the building. Your employees need to know how to use it correctly.
Thank you. And this all goes back to, again, we just want a healthy workforce, and we are in the middle of a pandemic. We're starting to see cases go up again, and we have healthcare workers or support staff that really want that added level of protection. Maybe they have someone at home that's immunocompromised, and or maybe they themselves have risk factors, or maybe none of those things. They just don't want to get COVID, and they really want to be able to utilize this additional level of protection. And I'm glad that our supply seems to have improved within the US. So then the other tier here is respirators provided by the employer. So, and I'm sorry, that heading, yeah. So for respirators and provided by the employer. So the employee can bring in their own, but you may have more product now and you want a healthy workforce. And you're going to say, use the product we have here. Maybe we want all of our registration staff because we know that they're interacting a whole lot with the public, or, we want to make this available to all of our support staff or healthcare staff. Even if they're not taking care of COVID or suspected COVID patients or have other hazards, we want to make it available because we know that this higher level of protection may be beneficial. So the employer can also choose to provide that. And in those situations, what they must do is ensure that they provide training to staff on how to utilize that respirator, and it needs to be in a language and a literacy level that the employee understands and allows time for questions. And then employees must demonstrate some type of understanding of the material, which they can accomplish through a knowledge check, or you can just have discussion after the training to accomplish that. So we'll correct that header, but yeah, this is if the employer is providing that. If the employee is bringing their own, they just need that little statement provided to them. Next slide. All right, so what does that training need to include? So the OSHA ETS very specifically says this is what you need to train on. So includes how to inspect, put on, and remove the respirator, limitations and capabilities of that respirator, procedures for storing, maintaining, inspecting it, reuse policies of the respirator, how to perform a user seal check, that's a big one, as well as recognizing medical signs and symptoms that may limit or prevent the effective use of the respirator and when you need to discontinue use. So all of those need to be included within that training. And we have a whole bunch of resources listed at the end. There's a lot of really great stuff that's already out there and been put together. So you may not have to reinvent the wheel and create your own thing. You can utilize stuff that's already accessible. And one of the things I really want to encourage when it comes to information on donning and doffing, cleaning, maintenance, storage of these devices, please refer to manufacturer instructions for use. There's a lot of great information out there provided directly from the manufacturer, and every device can be a little bit different. So you want to be familiar with whatever product you're using. And they have all of these really great booklets and information available. And the good thing too is a lot of times it's in multiple languages. So if you need a different language, it's right there available to you. And you can also look up training videos and all kinds of great stuff. In addition to that, also be aware of your own facility workplace procedures, and you can utilize or reference those as part of the training. So I want to touch on reusing, filtering face piece respirators. So CDC has been continuing to update their guidance on this mechanism that we've really needed early on. So in May, they updated their recommendation and said that healthcare facilities should not, at this point, be using crisis capacity strategies, that our supply of PPE, including respirators, has improved within the country. So they say that we should no longer be purchasing non-NIOSH approved respirators, and any respirators that maybe we were decontaminating in the past. I know a lot of facilities utilize their sterile processing or UV lights or other things to try to decontaminate these as part of the reuse process. They recommend we go on and toss those. And really, they discourage reuse of single-use respirators at this point. So facilities hopefully have felt that relief and are getting the products they need and can go back closer to that single-use process. We may still need to use extended use for practical reasons as well, where you're wearing that respirator throughout the shift. but then being able to toss it at the end of the day and get a new one every day. The OSHA ETS does give us some a little tiny bit of wiggle room, though, if reuse is needed. And just as a reminder, CDC, World Health Organization, they put out guidelines, and we certainly want to implement and follow those. But this is this is OSHA. These are standards, and we need to follow these, or there are penalties. So if you are reusing devices, you want to make sure you are following these steps. Obviously, we want to not reuse respirators if they're visibly soiled or damaged. We need to make sure that they are stored in an appropriate way. That's in a breathable container between uses. And they specifically say that there needs to be a 5 calendar day gap between uses. So maybe you've worn it all day one day, you put it in your paper bag, and then you have to wait 5 days before you can reuse that. And then, of course, in addition to that, making sure it's not damaged, that we can still get that good user seal check, making sure the employee knows to do hand hygiene before doing the seal check and when handling that respirator, because it is considered contaminated, and that you cannot reuse that respirator more than 5 days total. So that would be, they wear it one day, we have 5 day gap, they wear it one day, 5 day gap, and you repeat that no more than 5 days total. So of wear.
Do you have a question?
Yeah.
Are there any suggestions for how to approach facilities that have not provided a fit testing program for their employees?
Okay, so the question was about facilities that have not provided fit testing for employees. And so I was kind of curious about this. So, for example, maybe a long-term care facility that historically did not take care of patients who had airborne illnesses and did not need to use N95s, but now maybe even have a whole COVID wing where they're caring for those patients. So, we really want to be a helpful resource. And if you need some assistance with how to perform fit testing, or just where to go to know how to do that, or to become familiar with that full respiratory protection plan and kind of the things that needs to be set up for that, we have our contact information listed, and I would encourage you to reach out to us, and we can help you connect with those resources. I know that we've worked with some facilities thus far to help facilitate that already. So we're happy to help do that. And it may be that, Ruth, I don't know what your thoughts are, but we may consider looking at that as another training opportunity or webinar all in of itself.
I think definitely that understanding how to update your respiratory protection standard, how to actually use respirators. What do you need to do if you are getting respirators into a facility? What is involved in fit testing? You can train individuals within your facility to be that designated person. It does take there is some training that needs to occur, but it certainly can be done. And I think in the long run, it will help you manage the expense associated with that, and also be able to be part of the solution to your individual facility. So please remember, as Sarah said, this is not something that you can say, well, we've never done that before and everything's been okay. This is our new reality. And so we need to make sure that you have the capability to do that. So we can help you with a sample plan, what it is that you need to purchase in order to be able to do fit testing, what all is involved. And the biggest gap that we have had is having facilities to actually have respirators on site. And many of you may have had respirators that you have stored in a little trailer out back, and it's been in the hot sun repeatedly. It gets really hot in the summer and then very cold in the winter. And then when you take those respirators out, you can tell that those straps no longer have any elasticity to them at all. they really have become unable for you to use them. So we can help you then with some of those choices, and even just some ideas on respirators that might work for your facility. Now, our problem is always, how do we make sure that we have enough supply? And you may have encountered this also if you have never ordered respirators before, and now you are trying to place an order. Sometimes you get bumped down to the bottom of the list. So it will be working with your whoever is ordering your supplies, see what you can get, and then we can help you address some of those issues. But I think you're entirely right. And I see Hudson is always taking notes, writing furiously, but I think we certainly need to add this to the list of programs that we have upcoming.
And Sarah, there's one more question too that came up, it looks like 4 times, and it's really around, is OSHA, just for clarity, is OSHA saying that you can wear only a surgical mask as long as you're not doing an aerosol generating procedure? Or should the recommendation still be, and is the recommendation still to wear N95 or higher when caring for confirmed or suspected COVID patients?
Yeah, my understanding, and please, Ruth, hop in if correct me if I'm wrong, but I believe the recommendation is to wear N95 when caring for suspected or confirmed patients. And I know this has been such a difficult topic because guidance has flip-flopped, and it was like, you can wear a regular surgical mask, but when your supply of N95 improves, you want to flip back, and it's kind of gone back and forth.
And
I think that the intent is to ensure that we have employee safety. So remember, a patient with COVID that is in a healthcare facility, this is a respiratory infection. So I have yet to see a person who requires care in a healthcare facility who has COVID that isn't coughing. So this is just a reminder that, the coughing patient is an aerosol generating patient just by nature of that cough. And so at least I have to be considered to be generating aerosol. So, think about the safety of our personnel, and it would be very difficult just from a logistics perspective to wear a mask in the room. Then if we need to then switch out and have a respirator and switching that off inside the room. Instead, we're trying to think of helping as you develop your procedures to think of a practical way that not only makes sense to your employees so you can teach them to that standard, but also enable them to consistently apply the safety precautions.
And I think where that's coming from too is there is that infection control guidance with CDC that has 2 parts. So under section 2, it talks about universal source control, and it talks about the sort of level of transmission within that local community. So there is a mention there, to your point, for those of you that asked that question about the use of a well-fitted face mask. But that is for universal source control. Like Sarah said, it's not for the care of a COVID patient. But an employee could always certainly opt to say, I work in the ER, I want to wear an N95 or higher, and we need to make the accommodation to do that as well. So hopefully that clarifies that.
And I totally understand just things that changing constantly and having, every other day it was like CDC was updating stuff there initially. And so it is difficult to follow. For reuse, so we have our guidance for that filtering face piece respirator, which is like the N95, but also thinking about elastomerics or PAPRs, which are intended to be cleaned and reused. So it may be a helpful resource to your facilities to utilize some of these. And again, if we're going to reuse those, we just need to follow manufacturer guidance as well as facility protocols for making sure they're being cleaned and reused properly. So, and they do have those like the filter cartridges in them. So making sure that we read what the manufacturer says as far as how frequently those need to be changed and replaced. Under the Mini Respiratory Protection Plan, a fit test is not required. Now, again, remember, for the full respiratory protection plan, we still need to follow those guidelines. So for folks that are caring for suspected or confirmed COVID patients, or just our traditional airborne or other hazard settings, we're going to follow that. But for the mini plan, it does not require fit testing, but we also have to understand that then there are some limitations with that. And that's why that user seal check is so important. And we need to make sure that everybody's trained on how to do that appropriately, and that they are doing the seal check every time before they put on their respirator. And there are two different types of seal checks. Again, you want to refer to manufacturer instructions for use on that, because some certain types of masks, you may not be able to perform both types of seal check. So just double check to see what they recommend. And then I've included in the next two slides just some information on how to do that. But there are tons of wonderful resources out there, videos and handouts. And we've got some links included that you can reference, but this is really a very important piece to respirator use, is just making sure that staff feel comfortable, and every time they put these devices on, they're getting that same kind of secure fit so that it is providing that full protection. Another important thing that we need to educate staff on and make sure that they're doing is knowing when to discontinue the use of the respirator. So while a medical evaluation is not required under the Mini Respiratory Protection Plan, if somebody in the past, for any reason, had a medical evaluation and was determined to be not medically fit to wear a respirator, then they should not be utilizing one unless they have a reevaluation and are medically cleared. So that's just something to keep in mind. But above and beyond that, we want to make sure staff are educated on signs and symptoms to look for that might indicate they need to take off that respirator. So things like shortness of breath, coughing, wheezing, chest pain, or any other signs related to lung or cardiovascular problems. All right. And then I think that just, a recap, OSHA's put out this, this guidance for us, these regulations, and we want to make sure that we can review those and implement them as efficiently as possible. And we know that that it will be enforced, and already have heard of places that have been getting visits across the country from OSHA to make sure that that we're doing everything we can to keep our staff safe. And at the end of the day, that's really what it's about, is to make sure we have a safe, healthy workforce.
Oh, Kelly has a question just before we end on our resources. So she says, just to clarify, formal fit testing is required for HCPs who are seeing COVID positive patients or PUIs, including those in the outpatient setting. Watching a video and a self-check would not suffice?
That is correct.
Correct, yeah. And any person who is going to be working with suspected or confirmed COVID patients would fall under just the normal traditional respiratory protection plan, and would need all of those elements that were listed on that slide: the medical evaluation, the fit testing, and the training for all of those pieces.
And they had one last question that was asked earlier, and I promised we would circle back. And it was about an IP, and they had asked that does the safety coordinator have to have some infection prevention experience? Can you all please confirm? From earlier, when you all had mentioned the safety coordinators, does that person have to have some infection prevention experience? Hudson, that was in your part.
And Hudson, I can answer that. I think I responded back individually that no, that they would not have to be an infection preventionist. But remember, any individual that is performing job responsibilities must be competent to do so. And that's something that is woven in through these standards. So whoever is going to be assigned with this responsibility needs to know what that means. So there needs to be training for all these individuals that have these different areas of responsibility for training or just simply educating. They need to be able to point back to the standard, provide correct information, and provide correct guidance. But they don't have to have a particular credential, but they need to be competent through education and training.
Yeah.
So I'm sorry.
Go ahead.
Well, I was just flipping through. I've got the standard here. And the wording or the way it's written is the COVID-19 safety coordinator must be knowledgeable in infection control principles and practices as they apply to workplace and employee job operations. The identity of the safety coordinator must be documented in a written plan and must have the authority to ensure compliance with all aspects of the COVID-19 plan. So
and that's actually what I was going to say. I think the easy part is to find somebody that has that foundational knowledge within the health system. The most difficult is to find somebody who's going to have the authority. So you almost really need to have a designated statement of authority from leadership that says, if I identify that Ruth is doing this, then I have the ability to actually deal with that, if you will, right? Not that she would ever be an outlier, because we know she's always very good. But just in case she was naughty with her following, if you will, of that. And one other question that came up too that I wanted to make sure we address before we conclude today is that there was a question in there about what is our obligation to accommodate individuals that they're on the healthcare team that have significant comorbidities. Do we have to move them to a different area? And there is a mention of that within the OSHA standard about sort of reasonable accommodation. And EEOC has actually put out a guidance document about this that I would encourage you to check out. And if your corporate counsel has not seen that, that would be the right place to go. We're not attorneys, and so we would defer you back to your corporate legal team and risk management, but there is an accommodation in there for considering, if you will, right? Considering is the key word, relocation or reassignment of those individuals that might have significant comorbidities like COPD or chronic diabetes that's not well controlled or something like that. But that would be an institutional-based decision. It's not an OSHA mandate. So I just wanted to clarify. It's an excellent question. I've actually, the first time I've actually had somebody ask that, but I wanted to make sure that we address that as well. Before we end, I did want to mention that Sarah and I'll be hosting a second piece on August 17th, where we're going to take the plan apart. And so one of the things included in the ebook were some different tools and resources to help you sort of start the process and really, refine your existing process that may be there. Many of you may already have some of this in place, which is outstanding. Our goal is to give you sort of that practice specific tools and resources. And so on August 17th, at the same time, we're going to reconvene and really talk about sort of taking that plan and implement it within your specific practice. And so hopefully that will be helpful for you as well. We do have our email addresses up here at the end, and also an additional barcode for CE. And again, a couple of you had asked that you had missed the one in the beginning. No worries whatsoever. We'll pull that information down from the registration report that Kim will run for us this afternoon. So Ruth, do you want to sort of see if there's any additional comments you want to add? And Andrea, I see you're back with us as well before we conclude.
I saw someone had asked a question about the plexiglass barriers. I think that was about the only one that we didn't answer, wanting to know if you have to have them, and recognizing that it's difficult to implement the barriers inside some enclosed spaces, inside nurses' stations, and so forth. So I know the verbiage is that if you can't physically separate, then you need to have some sort of barrier if it is structurally possible. So you may have areas where you physically can't put them up, but I think the question was that brainstorming had been done. Tammy had done that, and they looked at trying to figure out how they could make it work. If it doesn't work, it doesn't work. Then you may have to take other means to prevent crowding in the station ensuring then that, that people are wearing source control, that you are taking every opportunity to stress and support vaccination. Again, some of the information that has come out just is right in our faces that, we have 40% of healthcare workers vaccinated in some settings. We can't possibly control this virus unless we can engage our workforce more broadly in vaccination. So really focusing on that and thinking, what can vaccination do to help us address many of these challenges that are perhaps much more difficult and less reliable.
Well, and go back to your point, Ruth, about the hazard assessment and sort of the engineering controls and sort of the hierarchy of control, should I say. That's one of the things that a lot of people don't dig down into this. So there are options for you to implement based on your, for example, do you have a whole department that's vaccinated? Do you have a department that's sort of a mixed vaccination group? Are there ways for you to physically distance those workstations? So there's a lot of different flexibility in there. And all OSHA is looking for is for your reasonable accommodation and also sort of attempt, right, to do what you can within the logistics that you have. You can't physically move walls and put up plexiglass anywhere, nor do I really honestly think that will be a huge help, but this is one way that you can sort of augment your existing infection control measures. So hopefully that's helpful.
Great.
So Ruth and Andrea, do you want to go ahead and close us out? And a couple of people had asked about some of the questions. We will, Sarah and I will work on typing up an FAQ to those with some of the links and get those out over the next week or so. And then Kim is going to be sending out a Zoom link to each of you that registered for today for the August 17th, so that you'll automatically get that. And we'll also provide that link to Andrea to send out through the state listserv as well. And the recording is going to be finished this afternoon. So Kim, do you want to just let them know when that'll be available for them to listen back to?
Yes, that'll be available this afternoon, and I will send you all with that email the documentation, because I know some of you had told me that you could not get past the firewall. So I will put that in there, and some of the links we had posted. And there was also a question about some of the cleaning procedures, and I had mentioned in there as well, Dr. Garrett had done a prior Project Echo on that, so I'll put in those links as well, just as a handy little resource. So you will get everything by this afternoon.
Awesome. So Dr. Carrico and Andrea, I'll turn it over to you for our closing comments.
Andrea, how about if you close us out?
Well, I just want to say thank you to Sarah and Hudson and Ruth for this, and Kim for all your hard work and interpreting these guidelines for us. I know that it's going to be very helpful, and I really look forward to the next session that we have. Thank you all so much. We appreciate your partnership and look forward to being with you again. Thank you all. Have a wonderful afternoon.
Take care.